This patient was referred to me for a dislocated lens 45 years after surgery. You can see that the lens is barely visible. I'm going to start off the procedure by performing 2 paracentesis incisions. Next, I'm going to inject lidocaine and then a cohesive and a dispersive viscoelastic. And you'll see that the viscoelastic migrates completely posteriorly because there is no posterior capsule. Next, I'm going to utilize a micrograsper from MST, and you want to engage the haptic near the haptic optic junction. You want to stay away from the actual optic, and so you want to just be very careful. From an anterior segment surgeon, you want to make sure this lens does not fall posteriorly. That's the main priority at the beginning of the case. Now, to mobilize the IOL, I do recommend a bimanual technique. So with my right hand, I'm holding a micro holding forceps from Microsurgical Technology, and you can see these old IOLs have eyelets in them on opposite sides, and you'll see that the haptics are slightly different. Look at the angulation of the haptics. Now, to really secure the IOL, I do like to create my main wound, and I will be able to externalize one of the haptics through the main wound, and this will basically prevent the IOL from migrating posteriorly. And so you'll see that I'm just going to externalize the one of the haptics here. And so I'm doing that to mobilize the IOL. And then next I'm going to cut any vitreous both above and below the IOL. And in this particular case, there was not much entangled around the actual IOL. And my goal is to try and perform Yamane technique on this particular case. And so you always want to inspect the haptics. Now, interestingly, I noticed that this haptic had a terminal bulb, and I guess these old lenses were designed this way. I'm feeding it through my 30 gauge TSK needle, and it's just simply not going through. So I'm going to ask for a 27 gauge needle. Here I'm using the micro grasping forceps, and again, that terminal bulb is really getting in the way. So I'm now going to trim the bulb and see if this method will work. And so you're going to see this shortly. I'm trimming the bulb off right now. I'm going to zoom out just to show you that, and you'll see that the bulb is no longer there. And so I'm going to grab the 27 gauge needle, and even then, just the haptic size of these older lenses, they're just very big. And also the angulation of these haptics are not ideal for the Yamane technique. So I realized that I have to consider another procedure. Now you could externalize this IOL, but this IOL is made of PMMA. You need a very large scleral incision, and this will affect the fluidics inside the eye. So instead, I've decided to go with iris suture fixation of this lens. Now with iris suture fixation, I do like the haptics superior and inferior. Right now they're oriented nasally and temporally. I'm operating temporally. And so what I'm going to do is I'm going to, in a bimanual fashion, I'm going to rotate the optic. That way the haptics are superior and inferior, and I do find that the haptics oriented this way, it's just ergonomically better to secure the IOL to the iris. And so here, again, with a bimanual technique using both micro graspers and a micro holding forceps, you can see now that the haptics are both above and below. Always put viscoelastic to protect the cornea. And now when you have a bubble like this in the way, you always want to get rid of the bubble. You want an optimized view during all these complex cases. Now, as we know, with iris suture fixation, we want both haptics, once they're oriented in the right direction, as they are in this case, we want both haptics to be below the iris. So here comes the first haptic. I'm placing it below the iris, and I'm going to do the same thing using my other paracentesis incision. You want to be careful here. There's nothing holding the IOL back, so I'm going to perform this in a bimanual fashion. I'm going to tuck the haptic under the iris, but then you have to make sure that the optic does not fall back. So I'm going to introduce my micro holding forceps through the main incision. And then this is the exception where, you know, it's okay to hold the optic so it doesn't fall, but hold it as perfectly as possible, and then prolapse it above the iris. And now the iris is caught, I should say the iris has captured the optic. Now, to perform iris suture fixation, it's a bimanual technique. I'm using a Sinskey hook. I'm underneath the IOL, lifting it up so I can better delineate where the haptics are. I'm using a tenylproline on a CIF4 needle, passing the needle under the iris here, under the haptic and then out through the cornea on the opposite side. I like to do this in several steps, so I don't like to pull the needle out all at once. I find it's less traumatic this way, so I just push bit by bit until the needle is out through the cornea, and then again I pull the needle slowly. I don't need to pull it all at once, just bit by bit, and the needle will come out nicely here. So one more grab, and there's the needle. I don't need the needle anymore, so I'm going to cut the needle. Then we're going to repeat the same thing on the other side. Here's the Sinskey hook. Push it up. I can now better delineate the haptics. I'm going to pass the tenoproline on a CIF4 needle, capture the haptic, and then you're going to come out on the other side. And again, you don't have to do it all at once. Just push slowly until the needle comes out. And I just find this to be just much more of a gentler maneuver if you do it bit by bit, just pulling the needle, cut the needle, and now we have the suture strands on opposite sides. Now I'm going to perform the mechanical suture technique that requires a paracentesis equidistant between the two suture ends. Now I'm going to externalize both ends. Here I'm using a micrograsper again. Pull out one of the suture ends, and you want to make sure you pull out that end only. You don't want to pull the other end, and so you just want to do this very meticulously. I'm using straight tying forceps to externalize the suture. And now I'm going to address the suture that's inferior. To do this, I like to pull the suture closer to that paracentesis incision. I'm using a viscoelastic sweep technique where I'm pushing viscoelastic to create space and to also push the suture so that's closer to the paracentesis. And now I'm going to grab the other suture end and I'm going to externalize it. And so now we have both suture ends out through the same paracentesis. And again, you want to be very careful. You want to make sure you're pulling out the correct suture strand. If you pull the wrong suture strand, you're going to have to start all over again. So now I'm just going to zoom out, and then I'm going to tie the suture ends. Here I'm using the straight and curved tying forceps. Again, you just want to be very careful here. You could perform a 3-1-1, and then just do this very carefully. And as you do this, the suture will slide into the eye. So it's an intracameral knot. And so the suture goes in, and then 3-1-1. Here's the second suture, and then the third suture. And that completes the knot. So you just want to be very careful. And there we go. I'll just trim some of the suture ends so that they don't get in the way. And then I'm going to repeat the same thing, a paracentesis on the opposite side. And then I'm going to perform the viscoelastic technique here to push the sutures close to the paracentesis. Again, the viscoelastic sweep technique. And here I'm using my micro holding forceps to externalize the first suture. And again, you want to make sure you're pulling out the right end. So it's going to come out here, and then I'm going to pass, or externalize, I should say, the other suture strand. So the angulation can be a little bit unique in these cases where you're pulling out the suture. So you want to pivot through the paracentesis, and now I've got the suture. I'm going to externalize the suture, and now again I have the two suture strands. And again, you want to be careful. You're pulling on the correct suture ends. And now I'm going to trim the suture ends, and I'm going to go ahead and use my straight and curved tying forceps. And I'm going to show you a unique technique that I sometimes use. So here, as I'm crossing the suture, you're going to see that the suture loop will slide into the eye. But I'm finding that my curved, here we go, I'm finding that my curved tying force is not giving me the appropriate tension. So sometimes what I'll do is I'll call for the needle driver. So again, you'll see it's really not sliding in the way I want. So here's my needle driver, and then the knot goes in much better into the eye. And again, I'm going to call for the curved forceps again. And this time it slides in well, and then the last throw. And so this knot's going into the eye. Now I'm going to push the optic into the behind the iris, I should say. And you can see how stable the IOL is now. Now the two suture ends, I have to trim the suture ends because I don't want them to be caught to the endothelium postoperatively. So here I'm trimming them with a horizontal scissors from microsurgical technology. And once I've done that, I can externalize the ends that are outside the eye. And again, I'm going to do the same thing here. I'm going to trim the suture ends. You want them to be short. Now you want to be careful. You don't want to cut the actual knot. Otherwise, you'll start all over again. And then I can externalize the two suture ends. And then the next step is to again check for any entangled vitreous or any prolapsed vitreous, of which there was none. Once I'm done on this mode, which is the ICA mode, I'll switch to IAC to get rid of any residual viscoelastic. I've also instilled myocol, and you can see that the pupil is well rounded, and these are because the suture passes were mid-peripheral, and that will reduce the risk of a cat's eye appearance that you can sometimes see. Here I'm hydrating my incisions with intracameral moxifloxacin, and that wraps up the case. Of utilizing a 45-year-old IOL, initially the plan was to perform the Yamane technique. I showed you the terminal bulbs were less than ideal and the angulation was less than ideal for this technique, and I've showed you the iris suture fixation. I hope you found this case to be useful, and thanks for watching.